Kate Crowley here at Teachers College, Columbia University in New York City. Welcome to Module 3.2 of our Cleft Palate Speech and Feeding video modules. With my co-authors, Dr. Miriam Baigorri and Miss Chelsea Sommer, we've created these video tutorials on cleft palate speech and feeding. This module, 3.2, demonstrates speech therapy strategies to address cleft palate speech. Before we get into this, I just wanted to speak about languages and speech differences across languages, very briefly. So I'm bilingual in Spanish, and there's certain sounds in Spanish that we don't have in General American English. For example, the ch. In Spanish, in certain Caribbean countries, there's a ch for the trilled R, so perro becomes pejo, carro becomes cajo, and then there's certain, like Mexico, Oaxaca, those are all pharyngeal fricatives that we have in Spanish that we don't have in English, certain dialects of Spanish. Also, in certain languages, there's glottal stops. We're going to talk about glottal stops here because it's one of the compensatory errors in cleft palate speech in General American English, but there are a number of languages across the world where glottal stops are part of that language. I'm going to show you a brief video of two women who speak a Mayan language in Guatemala who show you that the word sol, or son, and the word mama and papa, mother and father, all three have glottal stops in them as part of that language. ¿Cómo se dice agua?
Ha. Ha.
¿Cómo se dice peche?
Tú. Tú.
¿Cómo se dice perro?
Sí. Sí.
¿Cómo se dice luna?
Po.
¿Cómo se dice luna?
Po.
¿Cómo se dice mariposa?
Pepem. Pepem.
¿Cómo se dice sol?
Sae. Sae.
¿Cómo se dice mamá?
Na. Na.
¿Cómo se dice papá?
Wa. Wa.
The next video we're going to look at is Amharic by Miriam Baigorri, who is an Ethiopian SLP who now lives in Washington State in the United States. And she's going to talk about a certain sound called ejectives, which they have in Amharic that has to close the vocal folds and then create sort of a suction, and then the sound comes out. And you'll see we do not have that in General American English. But when you're working with children who speak other languages, you want to think about what is the sound system of those languages.
We have 5 ejectives in Amharic. The one which is bilabial sounds like this. And the corresponding plosive sound is T. P versus P. The next one is the alveolar ejective, which sounds like T. T. And the placement is the same place with T. And the next one is the fricative S and S. The ejective S and the fricative, the corresponding fricative is S. And we have another ejective, the velar one, K. And the corresponding plosive sound is K or G.
Now, can you just tell us the ejectives? Do they use a glottal stop with the ejectives?
No.
No, huh?
No. Yeah. The ejectives have the double articulation at the glottis level and at the place where the tongue touches the palate.
Okay.
So, t, k, s, and ch, I mean.
Some languages have very similar sound systems to General American English, the dialect I'm speaking. For example, I'm going to show you now a video of two gentlemen speaking in Woolof in Senegal. And you'll hear I have them count from 1 to 10, and the sounds that they are using are the same sounds that we share in General American English. Can you please count to 10 in Woolof? 1,
benn ñaar ñett ñeent juróom juróom benn juróom ñaar juróom ñett juróom ñeent fukk.
How do you say no in Woolof?
Déedéet.
How do you say yes?
Waaw.
How do you say mother or mom?
Yaay.
How do you say dad?
Baay.
So here we go, talking about cleft palate speech therapy. I always say about this area that it's not terribly difficult, but it's specific. But here's where it shares a lot of features of basic, solid articulation therapy. We look at placement. How are the articulators placed? The lips, the mouth, the tongue. The manner, is it a stop? Is it a continuous sound? And voicing, is it voiced or voiceless? We'll talk more about that. As with good articulation therapy, we follow a multisensory approach. So we see what kind of prompts and cues can we give to that child to really, or this patient, to really understand what we're getting at. So we do auditory, tactile, and visual cues. It's classic Van Riper speech therapy. We also think about developmentally appropriate sounds. So what sound are we going to work on in therapy? Well, let's see what's appropriate for the age of the child. And we begin with those sounds if they're stimulable, but you might have a 4-year-old who's stimulable for some clusters of S, which it would be a surprise more than an earlier sound, and then you might use that. But that would be more the rarity versus what you'd most commonly do. Right now we're going to talk about compensatory misarticulations. So these are the habits that children and patients form when they have an open cleft palate before it's closed. Let's talk about an iPad. So here's a picture of my mom, Jane Crowley. If she were given an iPad, she might not know how to use it. My mom, by the way, my mom would know how to use it. She'd figure it out. But many people don't. You're given an iPad, and that's the surgeon giving the patient a quality surgery closing the palate. But the patient doesn't know how to use it. The speech therapist comes in and shows the patient how to use the new mechanism, the new velopharyngeal closure they have, just as we might go in and show the patient how to use their new iPad. Now, no matter how great that iPad is, no matter how good that surgery is, if I'm not good at teaching the person how to use that iPad, that beautiful surgery is going to not be that useful. Sometimes the first surgery happens and the iPad or the surgery still is not functioning well. You may need a new iPad or a secondary surgery for speech. And again, we as the speech therapists, we don't just train people how to use that new mechanism. We also help understand whether that iPad can really work or whether it needs some kind of adjustment, which is the same thing with the initial surgery. Does it really work so the child can produce sounds appropriately, or does there need to be another surgery and some kind of adjustment so that new mechanism will work? So let's talk about placement. We teach placement. We focus on the correct sound production, not the error. So for example, if the child can't make the patient can't make the high pressure ba, pa, ta, da, ka, or ga, let's just start with that. We might start with a sound that they can make. So a child with a cleft palate can make the nasal sound. So we might start with a ba, pa, ta, da. Now we're back to the velar sounds. The ka, ga.
So for example, you can do pa, ba. This is the same place as the nasal sound. So the nasal and pa are made in the same places. So it makes it easier for the child to learn it. So pa, ba. You can put your fingers on your nose like this to close off your nose, and then slowly make the sound for pa, ba.
Can you say pa, pa, ba, ma? That was close. You did ma. Now I want you to do this. So you think M and then you turn into a P like ba, gonna try it again. Pa.
Pa.
There you go. How about ba ba ba?
Ba ba ba.
You're gonna go from M to B. So let's do ba.
Ba.
Okay, let me try it. You know, do it again. Do it.
Ba.
There you go. Do it again.
Ba.
Do it again.
Ba.
Now do that. Ba.
Ba.
Nice. Do it again.
Buy baby a bib.
Buy baby a bib.
Again.
Buy baby a bib.
Or ta or da. Again, the placement is the same. And ta and da are said in the same places in the mouth. So it makes it easier to practice that. Da, ta,
But I really want you to focus on the air coming out of your mouth. So, da. Close. Da. That was good. Da. That's it. Da. Good work. Da. Da. Good work.
or ka, or ga. Again, these are sounds made in the back, and it also makes it easier for the child to say it. So these are sounds that you can use to practice, to help your child practice to say the oral sounds. Ga. Ka.
Blink.
Blink.
Sink.
Feet.
Ink. Eat. Say it again. Ink. Eat. Pink.
Peak.
Donkey.
Donkey.
Stink.
Stink.
One more, right? Link.
Link.
Like a link. See? It's a link.
Link.
Pink.
Peak.
Ink.
Ink.
What about that S, which can be a tough sound to get to? Well, if we have the T, and we say it's a bunch of short T's all put together, like same place, it goes from being a stop to being a continuant.
Let's try it. Your turn. That was
Excellent.
beautiful. Can you do 10 more of those? Good work. Nice job. That's 2. 3. 4.
Here's what's happening at velopharyngeal closure in the strategy.
Sissy sees the sun.
This is the sun.
Okay, make that T. Okay.
How about the ch? The ch is the same place as the sh. Ch, 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 sh. The sh. Sort of you're keeping your inner mouth in more or less the same position, but you're moving your lips from the sh. And you could go backwards where you go start from the S sound.
So now make your sound for me. All right, now keep doing that, and I want you to pucker your lips, going. Close, but keep your tongue in the same place because you have it. Right. Better.
Caution clinicians with the remember, don't put any space between the and the s. We've seen too many people go s. And what happens is people lose the patients lose the understanding that it's stop going into a continuance. So you want to do it and you can see the tactile and visual clues I'm giving as well. Same with the shh. You want to use that shh. So keep it continuous. Do not stop in between. Shh, s. No, that's your caution, clinicians. Rather, keep it continuous. Shh, and so now we're going to look at the velar sounds, focusing on correct sound production, not the error, right? So the velar sounds are the k, the g. So what we can do is think about gargle with the back of the throat, but thinking that the gargling is happening more forward, like ga 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 ga. Did you see that? All right, I'm gonna try it with you. Just a little bit of water. Head back and go ga 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 ga. Go ahead. Ga 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 ga. Ga 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 ga. Don't move the front, use the back. Ga 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 ga. All right, we're getting there, girl. Take a little bit, only a little bit, and go ga 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 like you're gargling. Ga 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 ga. Just a little bit. There it is.
Ga, ga, ga.
Or the lion sound. We can also take a tongue depressor and push the back of the tongue up and make it jump.
Okay. Try again. Look at me.
We can also show where the k is made using a mirror or a flashlight so the child can see in. You see where the back of the tongue is up against that palate back there? And it jumps right off.
Have a look. That's it. Do it again.
The other way to do a k is to start with a which is a nasal sound and has the same position. It's a velar sound. We call it making a sandwich with the tongue. So have a look at this. The sandwich is the teeth, the tongue, and the teeth. So you keep the teeth in the same position, the tongue in between. That helps the child from moving that k back into a pharyngeal fricative or a glottal stop. How about focusing on manner? So we just looked at placement, now we're going to look at manner. Whether the sound stops, we talked about the ta ta ta, or flows is a continuant like the s or the sh sound. One way to do this is to take a little ball of paper, put it on your palm and put it on the child's palm and go p, so they can see it fly through the air. P. It can become a great game of watching this fly through the air. Yes.
Do it again.
All right. Now I heard a little bit of. I heard a little of that, so don't hear that. I want to keep that quiet. Yes. You can also put a tissue in front of the child's mouth to show it how it goes. Pa, pa, or s, and watch it move. Sometimes we also use the tissue to help the child or the patient see pa, pa, pa. This little flick sometimes really helps to get the understanding or the memory, the motor memory of the pa, s, ba, ta, ka, ga, to get that air trapped and then exploding out.
Da,
Na.
da,
Na.
da.
Da.
That was good. Da,
Da.
da, da.
Let's try to pop, pop.
Pop. Pop. Pop. Pop. Pop. Pop. Pop.
Beautiful.
Good, yeah.
Remember, a deep breath and until you run out of air.
These are just little strategies we use, visual, tactile, and auditory, that really help patients understand what's going on and how to change their compensatory strategies now that they have the new surgery. All right, then we can teach voicing. So we've now talked about placement, manner, and voicing, whether the sound is voiced or unvoiced. So p is unvoiced. We can put our finger right here, p, p, and the motor is not on. But then when we say the b, we can feel that b, b, b. So we turn the motor on by going, turn your motor on. If we want the child to say ba, and they're saying pa, we might say, turn that motor on, ba, ba, ba. That often works. Another strategy, if the child is saying a ba and can't say the pa, we might say, okay, take your ba and whisper it, ba, ba. Now, of course, this can work with any voice sound. It could work with the duh. Whisper that duh. Whisper that ga, ga, ga. Whisper that zzz, zzz, right? We could also try making the p louder. Let me hear that p, ba, ba, to turn it from a voiceless to a voiced. Again, you could do it with the t to the da. Let me hear that t, da, or the k to the ga. So it just depends on which way you want to move, whether you're moving from voice to voiceless or voiceless to voiced. And then, what are the strategies that work for this patient? We know a lot of strategies because we actually have to have a ton in our toolbox because we never know what's going to work for a particular child. Okay, so now that ends the overall view of the articulation therapy we do with cleft palate speech. Now we're going to get into the particular compensatory errors. In the next module, we will look at nasal emissions, glottal stops, pharyngeal fricatives, pharyngeal stops, mid-dorsum palatal stops, and nasal rustles. All the strategies we use to try to address these cleft palate speech errors. Now, for all of these strategies that were talked about in this module and that we're going to talk about in the next module, we always say that these strategies are not going to work. Cleft palate speech will not change by speech therapy alone. If the parent does not learn the strategies to prompt the child and work with the child at home, the speech will not change. The good thing about this work is if you're given a good iPad, that is, you have a good surgery, and you're given a good iPad, and you know how to do the speech therapy, it actually moves very, very quickly if you have the parent involved. So we looked at placement, manner, and voicing. Traditional traditional articulation therapy for cleft palate speech therapy. Now we're going to look at some of the compensatory errors that are more classic with cleft palate speech. Nasal emissions, glottal stops, pharyngeal fricatives, pharyngeal stops, mid-dorsum palatal stops, and nasal rustles. Again, make sure you got that parent involved and working on those new strategies several times a day, even if it is when they're walking down the street or driving a car or being picked up from school. That's when the real motor learning happens. This is the end of Module 3.2. Join us in Module 3.3. More information is available at leadersproject.org.